Clinical Guide to Contemporary Cardiac Interventions. A guideline aligned framework. Some interventions are coronary, others are valvular, others are related to heart failure, others, some of them are related to electrophysiology, and still others are related to congenital problems. There are many guidelines, they frame decisions, but heart teams individualize them along with taking informed consent from the patient. So, coronary issues are addressed through PCI, cabbage, FFR, and imaging. Valvular problems are addressed through transcatheter or surgical repairs or edge to edge repairs through transcatheter techniques. Electrophysiological problems are addressed through ablation, pacing, defibrillator installment, and resynchronization therapy. Heart failure is addressed through EMPLA, ECMO, and LVAD. Congenital problems like ASD, PFO, VSD may be occluded through different structural umbrellas and things, and pericardial emergencies like pericardial effusion, tamponade may be addressed through pericardiocentesis. So, interventions are not done simply because a lesion exists. They are done to relieve symptoms, improve prognosis, prevent sudden death, or treat instability. So, indication is foremost and first thing, and symptoms, survival benefit, and clinical instability is taken into account. The risk is assessed for any bleeding, whether patient will have kidney injury, stroke, or patient is frail, or has comorbidities like chronic obstructive pulmonary disease, etc. Anatomy is assessed for coronary valve, vascular access, etc. And contraindications like patient is suitable for dual antiplatelets or not, patient has active infection or not, his blood sugar levels are controlled, he's not in fever, and he's not having any major other than non-cardiac severe issues like malignancies that limit his lifespan. So these are taken into consideration. And evidence-based practice is promoted. Heart team approach is uh, encouraged. Guidelines and the class of indication is taken into account, along with taking patient on board in form of informed consent. Coronary intervention, diagnostic coronary angiography will define anatomy in acute coronary syndrome and high risk stable angina, and radial access is preferred according to new guidelines. In stenting, balloon predilation, and drug-eluting stent, in FFR or IFR, physiological pressure via measurements are done to determine whether an intermediate stenosis will benefit from stenting or not. IVUS and OCT give us virtual histology and is used especially in left main and complex coronary intervention. And surgical bypass is a very good procedure in mortality reduction in triple vessel coronary artery disease, left main stem disease, LAD disease, especially in diabetics. Very important to go for coronary artery bypass grafting. The 120-minute STEMI timeline is that if a PCI capable hospital is there, you go direct for PCI. If otherwise, go for fibrinolysis and then transfer for angiography with rescue PCI. And in other cases where the patient is unstable in form of ongoing shock, ongoing ischemia, acute heart failure, then invasive strategy is immediately proceeded with. Non-STEACS has a triage matrix, very high risk cardiogenic shock, refractory pain, life-threatening arrhythmias, immediate angiography is warranted. In patients who are having dynamic STT changes, positive troponins, and high risk Gray score, they are favored for early invasive less than 24-hour procedures. Lower risk patients with troponin negative status, stability, and no signs or symptoms of ischemia, selective non-invasive testing is done. Non-STEMI does not automatically mean immediate cath in every patient. Timing depends strictly on instability and risk stratification. Grace, CALIP, TIMI scores are taken into account. Grace is the most validated and updated tool. Chronic coronary syndromes, triple S indication, symptom relief for refractory angina despite guideline directed medical therapy. Survival problem in left main stem disease with diabetes or multivessel disease with EF below or equal to 35%. And high risk anatomy or large ischemic burden may be favored for revascularization in chronic coronary syndrome. Revascularization doesn't only mean stenting, it includes bypass surgery as well. And whenever you are referring a patient, obviously you will clear the whole picture for the patient's benefit. So when the patient is having left main with complex anatomy, high syntax is cabbage candidate. Left main with intermediate or low complexity, PCI may be a reasonable alternative. Diabetes with multiple vessel involvement, especially LAD bypass surgery is preferred. 1 to 2 vessel disease normally have no proximal LAD medical therapy unless refractory symptoms. And patient is a surgical candidate, prohibitive frailty, and the patient is having poor prognosis with anesthesia related complications. Possible PCI may be offered for the patient. Cabbage saves life in LAD and low EF, left main disease, diabetes with multivessel disease, three vessel complex disease. PCI complications and DAPT reality. Early PCI complications include bleeding, hematoma, stroke, perforation of the coronary, contrast, and nephropathy. And late complications are in-stent stenosis and stent thrombosis. The DAPT hard stop is inability to adhere to 12-month DAPT is a hard clinical stop for elective stenting. Aortic stenosis, valvular and structural. Symptoms of angina, syncope, and dyspnea. Asymptomatic but abnormal exercise test with rapid progression. Depressed LVEF. Very severe valve obstruction, exercise-induced symptoms are fall in blood pressure, and LV dysfunction or low EF indicates aortic stenosis to be treated through intervention. Surgical versus transcatheter. Surgical is favored in younger, low risk, below 65 with life expectancy more than 20, while TAVI or TAVR is for older or frail with age above 80, high prohibitive risk and life expectancy more than or equal to 1 year. TAVR complications are stroke, vascular injury, paravalvular leak, and need for a permanent pacemaker. Heart team shared decision making for intermediate age and risk. Mitral interventions. In viral stenosis, ideal target is symptomatic severe MS with favorable morphology. Hard contraindication is LA thrombus, moderate to severe MR with mitral stenosis. And in MR, primary degenerative is surgical repair, if durable repair feasible and acceptable risk. Secondary or functional MR is transcatheter edge-to-edge repair reasonable if symptomatic or optimized on GDMT, guideline directed medical therapy. Anatomy is favorable and EF is 20 to 50%. MR may be intervened. TR, severe symptomatic despite medical therapy with high surgical risk. TER or replacement of the valve. Pulmonary regurgitation or stenosis, post congenital like in TOF, repair transcatheter pulmonic valve replacement is done. Pulmonary valve stenosis that is native is treated through balloon pulmonary valvuloplasty. Left atrial appendage occlusion is for stroke prevention in atrial fibrillation with high stroke risk with contraindications to long-term anticoagulation, and is inserted in LA appendage, or patient is surgical if undergoing concurrent surgery. This LA appendage may be removed. Emergency electrical therapy. For VFR, pulseless VTR synchronized defib. For unstable SVTR, AF synchronized. Cardioversion for symptomatic bradycardia, transcutaneous or transvenous pacing. And the shock pentagon criteria for instability is systolic blood pressure low, heart failure, ongoing ischemia, consciousness low, collapsing, and shock. The shock pentagon criteria for instability in emergency defibrillation or cardioversion. The anatomical ablation map, AF, pulmonary vein isolation, AVR, TR, WPW, accessory pathway ablation, atrial flutter, cavo tricuspid, asthmas in apical atrial flutter, and AVNRT slow pathway is ablated. So successful AF ablation does not automatically stop anticoagulation. Decision remain based on thromboembolic risk of the patient. Pacemaker indication, pace, persistent, high grade or complete heart block. A, acquired Movitz 2 block, not reversible. Chronotropic incompetence with symptoms. Episodic sinus pauses with symptoms or sinus node dysfunction. Symptom correlation is key, no minimum heart rate, mandates pacing alone. Temporary pacing is a bridge to permanent pacing and is used in unstable acute MI, toxic reversibility, and post TAVR block. The ICD survival sheet for EF less than or equal to 35%, guideline directed medical therapy, NYHA 2 to 3, more than or equal to 40 days post MI or more than or equal to 3 months post PCI or cabbage. Secondary prevention path for survivor of VF pulseless VT or sustained VT that is not due to a reversible cause. Hard stop, avoid ECD in CRT combination log. left bundle branch block 150 millisecond wider. QRS complex EF35 less than 35%. 2 to 4 NYHA class. And patient is on guideline directed medical therapy. Devices resynchronization plus pacing or resynchronization per defibrillator when ACD is also indicated. Right heart cath is done for diagnosing shock. When cardiogenic, distributive, and obstructive shock states are confused, use right heart cath to clear the situation. In advanced heart failure, filling pressures, cardiac output, pulmonary vascular resistance, and for diagnosis of right heart failure or for pulmonary hypertension. Pre-transplant to evaluate PVR reversibility before committing to mechanical support or transplant, then right heart cath is done. So that is it. Thank you very much for listening. This was our clinical guide to contemporary cardiac interventions. This is Dr. Asif Allah from KMU IMS KDA cohort.